Like, okay.
Ladies
Sounds
first.
Yeah,
ladies first.
ladies first.
All right. Dr. Hassan is going to start with our sleeve gastrectomy technique lecture series tonight. Go for it.
Okay. All right. So I am Monique Hassan. I am a robotic surgeon, 100% robotic surgeon here in Temple, Texas. And this is my QR code. So if anybody has any questions, comments, you want a copy of some videos or anything else, feel free to reach out to me and I can send you any of those links. But I'll be talking specifically just about the Da Vinci sleeve gastrectomy. So in terms of the presentation, the overall presentation, I'm going to talk really about kind of technical things, the technical aspects, the setup. I really think that this is a great procedure that when you're starting out as a bariatric surgeon, to really perfect this procedure, and this procedure will lead you into, any other procedures that you're going to go doing on the robotic platform. In terms of technique, I'm going to show you two different ways. I started out doing 4 incisions, and I would say kind of 90% of my sleeve gastrectomies are with 3 incisions. And I'll show you how I do that. And I'll give you some tips and I'll talk to you a little bit about outcomes. So this is my table setup. One of the things that I am really, I think I'm known for is efficiency. And one of the other things I think that I like to give people who are starting out doing robotics is that you have to have a lean setup. Lean setup means that there's not a lot of stuff that your tech has to count. And because there's not a lot of stuff to open and count, then your turnovers can be much faster. And that's the ideal, right? Because everybody always says robotic cases are really long, they take a long time. And although they can take a little bit longer than a traditional laparoscopy, certainly you can do all that you can to kind of minimize the instruments and things on your back table. So this is my back table for every single robotic case. So I don't care if I'm doing a switch or a sleeve or a bypass or some sort of revision, but this is it for every case. This happens to be a sleeve because I do have 112 and 3/8 or 2/8 over there. And so that is my standard setup for a sleeve gastrectomy. So this is also, I think it's also important to kind of get the lay of the land in the room when you show up to your robotic OR. This is my OR. This is how we have it laid out. Obviously, where things are in your ORs may be certainly different. But this is how we have it laid out. And I am lucky and fortunate enough to have dual consoles on every robot that we have. I think the really nice thing about robotics is that it lends itself really nicely to teaching. So that's me and one of my residents in the middle. Teaching him. And then the other big thing too is get a chair that you're really comfortable in. Not that this case is going to necessarily take long, but when you're in the console in the robotic platform, you don't want to be rolling away or you don't want to have to be readjusting your seat. You want to be kind of comfortable. And again, that's the nice thing about robotics is that you actually can be comfortable. The other thing I stress too is that while my socks are really cool, I think it's really important to take your shoes off when you operate. It minimizes the ability for you to hit the wrong pedal because you have good actual feel of the pedals when you don't have your shoes on. And then obviously it's really nice to have cool socks on. Obviously, you don't want to have socks with holes. This is my port placement. So this is what I started out with. I converted my whole practice in 2021 to robotics, and this is what I started out with. I used a liver retractor that was the snake retractor that was in the right mid-axillary line. And then I did my arm one in arm one in that spot that's marked 1. And then my camera was in arm 2. Right in the middle, kind of 12 centimeters, or for me, it's just a handbreadth down from the xiphoid and cheating over to the right, just about a centimeter or 2. And then my arms 3 and 4. But I found was after doing a few cases, I found that arm four wasn't really doing anything. It really was just hanging out over there. So I started not using arm four. And so just coming up with the three robotic arms and then my liver retractor. And then this was the liver retractor that I was comfortable with, the snake retractor. I don't know if anybody else uses it in their fellowship. And a lot of people also use the Nathanson retractor. But what I found was with the snake retractor, I found that arm one kept hitting it, and then I was the only one in the room that knew how to adjust it. So sometimes on really hard cases, I would have to scrub back in order to fix it, in order to make sure that it was holding up the liver. So I really kind of just, after a while, just abandoned it. And then this is where I got to, and this is where I am now. So what I routinely do, and really I should on this diagram, I should really just mark that as more my arm three really out to arm four, because what I do is I still drape all four arms, all four robotic arms. And then if I need arm three, that would be my port that you would end up putting in after I get in if I need a fourth arm. So essentially, I dock arms one, two, and four, and I leave three right in the center, right in the middle. And then my resident who is at the bedside can just make an incision, insert the next port, and then dock arm three. And then we have all four arms utilized if we need it. So in terms of my incisions, I mark out all of the incisions. So I use just a hand's breadth. So as you can see here, so this is my hand's breadth and cheating over a little bit to the right. And then I just mark my incisions one hand breadth away from each other. And then my arm one is about a hand breadth away from my camera port. In this patient, he's a really large patient, but he also had a kidney transplant. So I was trying to make sure that I was north of his kidney transplant to make sure that I didn't hit it. So if I'm using all four arms, this is what it looks like. I showed you in the last slide what it looks like with the three incisions. And usually, even in the largest patients, I can really get away with utilizing just three arms. But I'll show you both procedures that I do. So this is my instrumentation. So in arm one, I universally always use the forced bipolar. The reason I use a forced bipolar is because when I'm doing a band or a band removal, band to bypass, can someone's not muted. Can you guys mute? There you go. So in arm one, I universally use the forced bipolar because I like to streamline all of my instrumentation. So it doesn't matter what actual procedure you're doing. It's the exact same instruments for every single case. So arm one is the forced bipolar, and like I said, I use that because of the force. Because of if I'm taking out a band, I can utilize that in that case. Arm two is always the camera. And then arm three is the workhorse, the vessel sealer. Arm four is the tip up for me. And then arm one is really where I do all of my stapling. Now, if you want to be a little bit more cost efficient, there is a little bit of a price difference between the tip up and the Cartier. So you can switch out to the Cartier. I like the tip up because it's nice and broad. And I'll show you in my technique, I think it works better than a Cartier does. So once I have all of my ports placed, before I even dock the robot, I place all of my ports. I put the patient in 12 to 15 degrees reverse Trendelenburg. And then as soon as that's the patient's in reverse Trendelenburg, and actually before I even move the patient, my 12 port, I actually pre-close that with a Carter Thompson. So when I leave the patient, I don't have to scrub back in to do anything. My resident can scrub back in and remove the specimen, and that's it. The port's closed. So once I put all the ports in, I pre-close 12. I give all the local in all of the incisions. Then I move the patient to 12 to 15 degrees reverse Trendelenburg. It's usually 15 to just make it easy for the anesthesia. I slide the bed all the way down to the feet so that we have enough room to dock the robot. and then the robot comes in and I dock all the ports. So if I'm doing just 3 arms, I dock 1, 2, and 4. I leave arm 3 kind of in the middle so that it's there, but it's not going to collide with anything. And then I scrub out and go to the console. So once and I actually forgot to mention, I also will put my suture. I put a suture in and a retract in before I also leave the patient bedside. So once I get in, I then do liver retraction. I use this liver retraction stitch. And I saw this on a video on, I don't know if you guys are on Surgeon or on the the Facebook bariatric collaborative group, robotic collaborative group. But this is where a lot of people share some videos and you can kind of pick up some tips and tricks. And so I was there at this, someone had posted a video and I saw this and I picked this up. So I use a 18-inch O V-lock. This is a really large needle. This GS21 needle is very, very large. And so you have to be uber careful. But this is what I use. It's like a modified liver hammock. They also make commercial devices that you can use to kind of hold up on the liver in this similar fashion. But I've just found that this is super cheap and it's easy for me. So what I do is with my arm 1, I lift up and you can see me just lifting up to see if there's a hiatal hernia. So I look really quickly to see if there's a hiatal hernia. And then I can say to my resident at the time that I'm doing this, that they can now scrub out and come to the console, especially if they're like a PGY3 or 4, so they don't have to sit at the bedside. So I take a really tiny bite at the apex of the, where you would come in, where you would bring your Nathanson in, and then I take that V-lock and bring it down towards the hiatus, and I take a really tiny bite at that hiatus, and then bring the suture back towards me. Sometimes if it's a fatty falciform like this one, I will actually go through the falciform and then I take another bite of the anterior abdominal wall over here on the right side of the patient. And then if it's a big floppy liver, this one's not so floppy, but I do like to bring this suture back towards myself. And then I'll actually just tack it into the anterior abdominal wall. I think one of the biggest things that I've learned about this technique for liver retraction is, one, it's nice because you can adjust it yourself, so that's a positive. The con is that that's a really large needle, so you can have some, you can have injuries, obviously. The barbs on the V-lock is much more gentle than using a Stratafix, for example, so that's why I've chosen the V-lock. And then the other thing I also think is super important is that you leave the needle in place. Because if you leave the needle in place, then you're not going to forget to take the liver stitch down because it'll be part of your count, right? And so I also, once I get my liver stitch and everything in place, then I have anesthesia bring down my bougie. I use a 40 French Visigy and then I have them put it to suction right away. So this is my forearm technique. I go retrogastric, so I open up the lesser sac. I get down kind of distal, and I just take a couple big bites. And I go distal and work my way towards the pylorus first. I don't like to backtrack, so I try to kind of guesstimate where I think I'm going to fire my first staple. And so I'll take some big bites there and where I think I'm going to do it. Then I take the tip up in. And I actually retract on that greater omentum, on the greater curve. And then I go in towards the fundus and I actually lift up retrogastric. And I take down any adhesions. And then I just take down the fundus. I take down the fundus. I like doing it this way because I think it's nice because you can see the crus really well from underneath. If they have a big fatty fat pad, it can be hard to see hiatal hernias, but you're not going to miss them if you are coming from behind, basically, and lifting up right on the crus. I dissect most of the fundus from the posterior aspect. And then you can see me directing my resident. And then basically what I do in this in this forearm technique, I will actually just come around the corner and just come straight up. And it really makes this dissection part really super easy. You can also, I'll show you a different technique, but you can also just leave all the short gastrics on, which I do with my 3-arm technique, with the 4th arm in place. But I think this is a great technique for people who are just starting out doing sleeves and really getting comfortable with the platform. And it's most like doing like your laparoscopic approach. I do dissect out the fat pad. I'm pretty aggressive because I really want to make sure that I see the angle of His and that I'm not stapling on this big fat glob and causing more bleeding up at the superior aspect. So this is the kind of early on sleeve gastrectomy for me in terms of doing the 4-arm technique. In terms of stapling, with 4 arms, it's really nice because you can have those, your arm 3, your vessel sealer, and your tip up just hold everything out for you, just like you would laparoscopically. I start with a blue load, and then I downsize pretty quickly to a white load. I think that it's more hemostatic. The robotic technology tells you if the tissue is too thick. So why not use the thinnest load that you possibly can do? And then it tells you that it's either too thick and then you can upsize. But I like using the white loads because the staple line, as you can see, is pretty clear. I don't use any reinforcement. I was never a big reinforcement person, but if you are going to use staple line reinforcement, you just need to remember to upsize your staple height on your loads. And as you can see on the last load, the last fire, I cleared off that fat pad, and so we're stapling right at the angle of His and really getting no dog ear and really kind of getting a good staple line at the end. So that's my 4-arm technique. And so with a 3-arm, I really kind of changed it quite a bit. And this is the iteration that I'm pretty happy with now. So I start out the same exact way in terms of getting into the lesser sac. Lift up, you want some big bites on that greater omentum there, just so you can really get into the lesser sac. In this case, I don't have that 4th arm. And so I do still track down distally, and then I just lift up on my bougie and then take down all those retrogastric adhesions. You can see this patient has a little bit more than the last one. And I'm like, I don't know if I should take those, but let's just leave it alone. And then I go up at the fundus, and this patient has a little bit better anatomy than the other one. But I take down the fundus, and you can kind of see really clearly, there's my diaphragm and there's my crus. If there's a hiatal hernia, a big hiatal hernia, you would see a big dip, and you would see a lot of things going, big hole going into the hiatus there. And then what I do is now I will just come back and just take a little bit more of the adhesions just to make sure it doesn't get caught on my stapler. I clean up any bleeding that I think is going to be a problem. And then I clear off the hiatus just like I did with my 4-arm technique. I'm just making sure that there's really nothing there in terms of the hiatal hernia. I still dissect off the fat pad, even though it's not very big in this patient. And then I'm ready to staple. So in this patient, I do the same thing in terms of starting with a blue load. And then what I do is same exact configuration, one blue and then the rest whites. And I really don't manipulate the stomach too much once I get the stapler in. And then what I do for my retraction, since I don't have that additional hand, is I'll actually use my vessel sealer, my arm 3, and the Raytech to hold everything up and out. And then those short gastrics are still on in order to help me in terms of my retraction laterally. And I think it gives me the same sleeve. And I actually think that my staple line's a little bit more straight compared to the 4-arm technique that I just showed you. So for all of my sleeves, I do a leak test. I do an intraluminal. I use a 40 French Visage. It's a dual function. So it's my bougie, and then I also use it for the leak testing. I use icy green. The dose that is really kind of varied. So sometimes I'll use 60, Sometimes I use 120 ml. Right now, everything's on back order, so I'm just using 60. But basically what we do is we reconstitute this vial reconstitute the whole vial and then put it into a 500 cc sterile water. And then I have anesthesia pull up 60 mLs, and then we just administer that through the Visage. I use the exact same thing for a bypass, any revisions, all the same things for my anastomotic leak testing. And so this is what it looks like. So I use my stapler to occlude the distal stomach and then inflate with icy green and inflate with air. And you can see pretty clearly there's nothing. And then once I'm done, this is again still my 3-arm. Now, I think this is a perfect opportunity for the resident to get used to the vessel sealer, getting used to using 2 arms. So now they can hold the stomach, pretty much not going to hurt a whole lot. You can get into still bleeding, right? Because everything's still attached. But this is their opportunity to really kind of get used to the tools of using the vessel sealer, manipulating their hands, and then I think for the younger residents, I think they feel more accomplished by having done something and then removing this specimen. So as you can see, they're struggling still a little bit with that. But yeah, then we spend the last couple of minutes of the case taking out the specimen. And so and learning a little bit more about the angles and the trajectory. So in terms of technical tips, so I think as soon as the patient gets intubated, the anesthesia should put down the bougie. I think most people would use a 40 French, or they could use a smaller bougie but stay off of the bougie. I kind of like just using a 40 French so you can really kind of just hug the bougie basically. I do mark out all of my incisions if I'm planning on doing a 3-arm. And then that way I don't have to swap arms. I don't have to take anything out. I can just literally dock arm 3 and then put my tip up of vessel sealer in that arm. I do like the retrogastric approach. Obviously, I think if you're starting out, you can definitely go around and take down all the greater curve and then roll the stomach over. But I do think it's super important to take down the fat pad because you want to really make sure that there's no hiatal hernia. I think it's also super important to downsize your staple height as soon as possible. You really want to, the bane of the sleeve gastrectomy, other than obviously complications from stricture or anything like that, is postoperative bleeding. And so you want to use the appropriate stapler height for the tissue. And I think the nice advantage of the robot compared to laparoscopy is that you can basically have it tell you which staple load to use. So I start with blue and then downsize to white right away. I like ICG for my leak test. I do think it's important when you start out that you definitely do leak test. Some people have gone away from that in sleeve gastrectomy because the leak rate is pretty low, but I have seen leaks with ICG for sleeves that I've done. In terms of outcomes, I firmly believe that less incisions means obviously less pain for the patient, but it has translated for us in terms of less pain medications prescribed. We do same-day discharge for almost, I would say, 80% of our patients, and we've had low readmissions and almost no ED visits for postoperative pain. And then we've had significantly high patient satisfaction scores. And then obviously the ultimate outcome is leaks or not. And we have not, knock on wood, I've not had a leak. I have not prescribed any narcotic pain medicine since January. And we're about to go into another year with hopefully nothing. So that's all I have. Here's my QR code again, if you guys missed it on the first go round. And if you have questions, let me know.
So I never get sick. I love this talk, partly because I like to see a different technique. I would be curious, anybody, excuse me, doing the gastric dissection or seeing that technique before? I mean, I
good. Yeah, good. Oh yeah, one person.
Yay. So curious, kind of going backwards, the leak test concept. Any of the faculty not doing leak tests, or any of the fellows not seeing anybody or not doing leak tests now?
Shayna, I don't do any leak tests or anything like that. No leak test, no intrappendoscopy.
Yeah.
I used to do intrappendoscopy, leak tests. I stopped doing that. I haven't had any issues. Uh, I do reinforce the staple line. I suture the staple line, more so for the fellows to train and practice on suturing before they start doing anastomotic procedures. So early on, when we start the training in August, they do the sleeve, they practice dissection, stapling, and then we start suturing the staple line. So that's kind of like our basic entry-level case. And then after that, we move on to doing the anastomotic procedures. But I don't do any leak tests.
Anybody else using staple line reinforcement or oversewing the staple line?
I'm using reinforcements. This is a major point of contention amongst the faculty here. But I still do it. I start with a green load. Usually I do 1 or 2 firings with the staple line, and then with the staple line reinforcement, and then I downsize, and I end up doing blue all the way up. I used to do white because sometimes the staple height gets very small at the fundus. But from our discussions on this faculty, I actually stopped doing that because I guess it is a little risky. The seam guard does fit on the white load, but I do worry about leak if I use it. So I'm primarily doing just green and blue right now.
Shayna, can I comment on the staple line reinforcement?
Yeah.
For the fellows, like if you look at the data, staple line reinforcement, we published a paper in 2016, I think, or 18 in JACS, looking at staple line reinforcement versus oversewing versus nothing, based on MBS equip. And we showed that staple line reinforcement and staple line reinforcement plus oversewing does help in terms of post-op bleeding rate. No difference in terms of organ space infection. At the time, MBS equip was not actually reporting leak. More recently, so that was based on laparoscopic data for the most part, Ethicon and Medtronic stapler. More recently, one of our fellows, Dave Fogno, who finished his training like 2 years ago, looked at MBS equip data again and picked up the robotic assisted cases. Now, we don't know if these were short form stapler or robotic assisted. That's another discussion. But we also looked at the same topic, again, staple line reinforcement, and we saw that the odds ratio, I think, was 0.8 or 0.9. So there's definitely a lower incidence of post-op bleeding, but that difference was not statistically significant for staple line reinforcement and oversewing. So when people look at my video, say, well, you published a paper saying it doesn't make a difference. Why are you oversewing? I'm oversewing for training purposes. But if you ask me about the data, you don't need to do that because staple line looks good. If it's well formed and it's hemostatic, it'll be fine. And that's what Monique is doing.
Yeah, and then the other thing, I mean, I just reviewed all the data for this. I just wrote a chapter on postoperative bleeding after sleep. And actually it shows that there's no difference, right? In terms of postoperative bleeding, there's nothing. The only thing it does show is that potentially oversewing can cause more bleeding just because you can have more bleeding from the needle holes. But again, it's not so high, the numbers are not so high. And is it, how are you doing your oversewing? Like there's so many different things. There's so many factors, and there's so many patient factors that are involved. But what I would say to you guys as fellows is that whatever your technique is that you're comfortable with right now in fellowship, I think that that's what you should do initially when you get out of fellowship, because again, that's what you're comfortable with. And then once you are out of fellowship and you've done a bunch of these under your belt, then you can start being like, well, I'm not going to do that anymore. I don't like this. I don't like that. I mean, there's so many different things that you can, start to peel away once you're in your own practice. But I think it's nice to be exposed to all of the things and all of the tools and understand what your options are, and whether or not you want to pick that up or not. There's data that definitely shows that buttressing lengthens your case, right? Because obviously someone has to load the buttress, but Ethicon has just come out with a different buttress that, basically snaps into the stapler, the Sureform stapler. So I don't know if that one is faster in terms of loading, who knows? But you have to consider all of those factors when you think about your case. But ideally, you want to be safe, and then you can be fast and efficient later on. So,
Did you reference our paper in that chapter?
no, of course not.
Oh my God.
Maher, your
very
head's gonna have to come down a
Very
notch.
nice.
I actually wrote a paper too, and I did quote you once or twice.
Oh,
No, don't tell him that.
Do not
Don't
tell
tell
him
him
that.
that.
That's a
don't
nice
Now
understand
he's
colleague.
how this
not even
works.
been the screen.
That's a nice
No.
colleague.
It just
Yeah.
started to
I
like
know, it just
up.
started going like
I don't know.
this.
I felt so bad for him.
No,
So I'm a
don't.
Julianne Lloyd of that philosophy, although recently I have changed a little bit, but only because I don't have an RNFA anymore. With an RNFA, loading up the staple line reinforcement was pretty straightforward, pretty quick. If you don't have the right help in the OR,
Right.
sometimes adjustments are helpful. And so now I oversew the staple line for sleeves and DSs and SADIs.
So I was going to say, actually, I think a part of the reason that I have continued to use a staple line reinforcement is that my surgical technician is like a Jedi at putting that thing on. I don't think it's actually costing me that much time to place it. But the other thing I do when I'm in the OR for bleeding is, I'm actually still sending my sleeve patients home the same day. So I'm like super, super cautious about all this stuff. But I will have anesthesia increase the blood pressure a little bit because, most of the times the patients have like, they're hypertensive, like 100s, maybe systolic. So I have them bring the patient's blood pressure up. I actually drop the pneumo to like 12. And then I wait a little bit while they're doing their counts in the OR and, whatever, I check my email. And then I go back and I look at the staple line again and look for areas and do a little bit of hemostasis before I get back at the bedside.
Yeah, so Scott Shakur actually published a paper talking about that. And they did find that they had one or two more bleeds that they called it silent bleeding. And I think that is also one of the reasons why I like my 3-arm technique, where I staple first and leave everything on, because by the time the residents finish taking down the remnant, then I can come back and look at the staple line. It gives me a few more minutes while the staple line's there doing whatever it's going to do, and then we look at it one more time before we leave. So I think there are all these different things that definitely has been shown. So some permissive hypertension, and then in that paper they dropped the pneumo down to 10, and then just kind of allowed the staple line to do what it was going to do. I do also think that higher pressure on your leak test will really kind of stress your staple line a little bit, and that is why I like doing it. But again, I think that if you, as new graduates from fellowship, don't do a leak test, I don't know that somebody is necessarily going to come after you for that, but I think it might be a better practice that you start out doing leak tests and then kind of later on abandon it as you get further along.
Protect
in your
yourself.
career.
I think at the beginning, protect yourself, be super cautious. It's also really nice to see what the sleeve looks like endoscopically. If you're going to use a scope, you can look for bleeding and leak that way, and it's a nice, if you're teaching fellows like I do, it's a nice skill to teach them at the same time. But I think sleep at night is a good thing. And also being able to document a negative leak test for at least probably as you're getting comfortable, it'll save you if for some reason something weird happens. Document everything you do. It's super important.
I also encourage the fellows to look up that in a recent paper, modified Delphi consensus statement that we published on the use of the short form stapler and the selection of cartridges. There's truly a paradigm shift now. Back in the days when I was a fellow, 2012, Dr. Rosenthal published an international consensus on performing sleeve gastrectomy, saying that it is not acceptable to staple any part of the stomach. Based on expert opinion, it's not acceptable to staple any part of the stomach with white, and it's not acceptable to staple the antrum with anything less than green. And now, based on that new expert consensus statement, it is, there's consensus statement. I mean, you have to look at the consensus. There's consensus agreement, consensus disagreement, but the highlights of that paper And again, I encourage you to look at that if you're going to do any robotic cases. The highlight of that paper is that it is okay to staple the interim with blue. Actually, experts are doing that. And it's also acceptable to staple the stomach with white if you're not getting that many compressions, meaning the tissue is not too thick. So
Yeah.
the
As
way
you
we're training our fellows is different than the way we were trained back in the days when we were doing laparoscopic sleeve gastrectomy. So just keep that in mind.
Yeah.
Yeah.
So Maher, as you bring up your slides, what level of evidence is that expert consensus decision on? Level of evidence.
It's expert opinion, obviously. So
Yeah,
it's lower, lower
That
level
expert opinion. I
evidence.
missed that. Okay. There's
Yeah.
no evidence on it.
Yeah, so it is expert
Y'all do
opinion.
it,
It is
but
a
there's no
consensus
evidence.
statement, though. Yeah.
Right. The other thing I wanted to do is just I wanted to answer some of the questions in the chat. So one person asked about
there
the
he
Titan.
is.
Yeah,
Demetrius is here.
the Titan stapler. So I have never used it. There are people that are using it. I think one of the highlights of doing robotics is that you can do everything yourself, right? So you don't need an assistant, you don't need someone at bedside to do something. So if you have to get back on to the patient bedside to fire the stapler, then I think for me personally, that's a no-go for me. I have seen some videos and the staple line looks pretty good, but I also just think it's a straight staple line for a curved organ. So that's my benefit. I mean, that's my thought on it. I think if you were doing laparoscopy, then I think then it's perfectly kind of appropriate in terms of bedside stapling because you're already there. It is also a bigger trocar that it has to go through, like a 23 or 21, I believe it is. So I definitely am not a fan of that. I don't think anybody is anybody using it?
No.
You're not using it, right, Maher?
The what?
19 trocar.
No.
Okay.
No, thank you. I mean,
And
it's an
then-
interesting concept. The risk of leak is really low with it, and it's I think very safe to use. I struggle with using it with a robot.
Correct.
I think your point is like hits at home. Just wanted to.
And then there was one other thing.
It was about a pre-op liquid diet. And so I know Liz commented a little bit, would love you to talk through it. And then also like the sizing down that you commented on as well when you make the decision to size down and size up on staple fires based on pauses.
So I actually don't kind of silly. I don't do that one pause or less. I downsize. I just if it clamps and it goes, then it's gonna go. Because then the next height's gonna be even thinner of the stomach because I'm marching up. So I have seen it on the second fire. My white load, it will pause like 3 or 4 times and it still will fire and it'll be just fine. And then the very next one, it'll pause 1 or 2 times. So I think that the more pauses actually is great because that means it's compressing the tissue. And I want a really tight staple line and I also don't want it, and I want it to be hemostatic. And again, I'm doing a leak test to literally like blowing out the stomach as you guys saw. So I think it really does stress it. So yeah, I don't really listen to that whole 1 pause, 2 pauses thing. And then we do a liquid diet, but it's only 3 days before, and we just do a modified low calorie, high protein diet, for 2 weeks pre-op. We do have big livers, and that does help a little bit. But honestly, I had a couple of patients, BMI over 60, that I did bypasses on, and they had no liquid diet because of just insurance issues, and we didn't have time to do it, and we had to just do the case, and their livers were fine. I mean, they were big, but it was fine. So I don't know how much more, how better the case would have been. It doesn't shrink the intra-abdominal fat, but it certainly can help. I've been using that liver stitch for the last 3 years and it's worked for almost every single liver. So I don't know.
Okay. Yeah. Maher, you're up. Your turn.
Well, thank you. Yeah.
Give you
So,
some reasonable time.
Yeah, I think I have 15 or 20 minutes, so I'll try to summarize the talk and move on to the videos. But my name is Maher Chaar. I'm the Fellowship Director of Bariatric Foregut at St. Luke's and the Director of Robotics and Innovation. So just as an introduction, I'm not going to go over the history of robotic-assisted approach in bariatric surgery, the controversy, surrounding MBS-equipped data and stuff like that. But just for you to know, the XI FDA clearance for the use of hernias was in Q3 2021. So this is a new thing. We've been doing it. We've been using the robotic approach for hernias for a very long time, but we were not allowed to show any videos. And actually, in the past, when we were showing sleeve, paraesophageal hernia, bypass paraesophageal hernia, we used to edit the paraesophageal hernia part out just because it was not cleared for hernia repairs. But now it is. So, and we're going to talk about that. So the advantages in my book for a robotic assisted approach, if you're fixing your hernia, whether it's a concomitant hernia or a staged approach where you have like a giant hernia, the entire stomach is up in the chest, you decide to fix the hernia and then come back and do a bypass 6 months later, which is something that I do on occasions. Or maybe you have a 4 or 5 centimeter hernia, you're doing a concomitant sleeve gastrectomy plus paraesophageal hernia repair, or even better, a bypass plus paraesophageal hernia repair. What are the advantages? So in my book, the advantages for a robotic-assisted approach, if we're going to talk about hernia repair, not sleeve or bypass, that's a different discussion, just hernia. Where are the advantages compared to the laparoscopic approach? Obviously, better visualization if you're up in the chest, better ergonomics. You have a third arm, which I cannot overemphasize. I love having a third arm. I use it as a Penrose. I pull that hernia sac down. You can reach higher, you can see better, and I think you do a better job dissecting that hernia sac and mobilizing that esophagus to get that 3-4 centimeter esophageal length in the abdomen. And if you look at some of the data that I'm going to go over quickly, I think that is why you see in some of those new studies that the long-term recurrence rate is much lower than that 50% 5-year recurrence rate that we used to mention to patients. So some of the questions, and I may not be able to answer all these questions, but some of the questions that come up when we talk about hernia repair using a robotic assisted approach: is the outcome better? Do you have less post-op complications? Is the long-term recurrence rate lower? Can you improve patient access by offering this hernia repair to sick elderly patients who are morbidly obese or maybe with severe health conditions? And what's the best and safest approach to train surgeons and fellow on that robotic assisted approach? I'll tell you, in my case, fellows don't do those hernia repairs early on. They start with sleeve, like I said, stapling, dissection, suturing, then the bypass. And then we start slowly dissecting the hiatus, doing that slip knot, dissecting the hernia sac. And then by the end of the year, they bring everything together, including paraesophageal hernias repair. So that's my typical port placement. If you look at my port placement for hernia repair, sleeve bypass SADI, everything I'm doing is done exactly the same way. I use a 2 left-handed approach. So I have 2 instruments in my left hand. I have 1 in my right hand, and I always use an assistant port. If I'm just doing a foregut heteromyotomy paraesophageal hernia repair, I'm not using a 12 port. It's all 8, almost a straight line. And then the assistant port is typically a 12 to pass sutures and use it for suction, bring the mesh at the end. And if I'm doing a combined maybe bypass plus hernia, sleeve plus hernia, we did a SADI 2 days ago. A SADI, it was supposed to be sleeve conversion to SADI. We did the SADI part, and then we had to re-sleeve the patient, and then we found the large hernia, and then we did the hernia repair. So it's same port placement. It doesn't matter what you're doing. It's the same approach. My ports look basically like that. I don't like the stitch to retract the liver, even though this is something that you can do, and it works for the most part. I like the Nathanson for different reasons. Especially in large hernias where I feel like the Nathanson exposes the hiatus a little bit better for me and give me that counter traction. But again, this is a left-handed approach. So you have 2 instruments in your left hand on the right side of the patient. This was a combined bypass foregut procedure. So you'll see a 8, 12 in your left hand on the right side of the patient, 2 8s on the left side of the patient, and the assistant port. We dock from the right side, and then Nathanson is from the left side. And then this is the final layout. We have a teaching console now, so it looks a little bit different, but typically, if the fellow is doing the case, I'm assisting. Sometimes I jump back and forth if I have to show him or show her something or do something. But if it's a simple case, I may not even sit at the console. I may just help pass sutures, retract if I have to. So I typically sit over here unless I'm doing the case or I'm helping the fellow. And that's basically the final layout for every single case that we're doing. And I try to basically use the same instrument. So it's always 2 cardiacs, a mega cut, and a vessel sealer. And that's basically it. If I'm doing a bypass, I may open the shears to make my enterotomies. But I use the cardiacs consistently because it's cheaper, even though with the hernia sac, I have to say the bipolar can help, because if you have some bleeding, you can buzz that bleeding instead of using vessel sealer. But for the sake of consistency, I just open cardiacs. So just like to go over the data, I'm not going to spend that much time going over that information, but take screenshots if you want, or I can send you that talk. I do encourage you to look at some of those published papers. If you look at the complications, and this is something that would probably come up if you're doing a robotic paraesophageal hernia, people will ask you, why are you doing it this way? Why not laparoscopic? If you look at the data, this is meta-analysis that was published in 2020. And the gist of it is that there's if you compare robotic to laparoscopic, there's a slightly higher esophageal perforation rate and respiratory failure favoring the laparoscopic approach. However, if you look at the high volume centers, this is not the case. And the other thing to keep in mind is that this is based on old data before the XI platform came out, and there's no data on hospital volume, on surgeon volume per se. And there's no clinical information on size or type of hernia. But just for you to know, this data is out there, and it's not that favorable. Now, if you look at more recent data, a randomized controlled trial looking at robotic paraesophageal hernia versus laparoscopic paraesophageal hernia, the data is pretty consistent. And what you basically see is same outcomes, higher cost. So it costs a little bit more. Outcomes, at least short-term outcomes, are the same. If you look at our data, I'm not going to go over that, but some of our data in terms of cost, there's no difference in cost between robotic and laparoscopic. And in some hands, robotic is actually cheaper because people are a little bit faster. The holy grail, though, for robotic approach is long-term recurrence. So if you look at this paper from Michael Awad, I like that paper. And we did something very similar, actually. We copied that paper and we submitted our data to surgical endoscopy. Hopefully it will be published soon and I'll be able to talk about it. I don't want to talk about it now because it's not peer reviewed. It's not published yet, but our outcomes, we have actually more patients, but the follow-up is not 5 years like in this paper. We have 2 and 3 year follow-up data, but it's very similar. So in that paper, the long-term recurrence rate is 9%. And so you have to keep that in mind, 9% long-term recurrence rate compared to what's in the literature. And this is an old paper looking at mesh versus no mesh. And if you look at that paper from Swanstrom, it's 54% recurrence rate. So the question is why? Because the procedure is exactly the same. We do it exactly the same. Why is the recurrence rate now 9% versus 54% in the past? And I think if you think about it, it has to do with the fact that I believe we're doing a better job. We're seeing better. We're dissecting better. We're going a little bit higher, mobilizing the esophagus a little bit better. And maybe that's helping improve long-term outcomes. So just to basically go over the approach, typically what I would say, and I'm going to play those videos and try to go over that. I divide those cases into right crest dissection, left crest dissection, hernia excision, hernia dissection, and then we'll go over the closure, mesh versus no mesh. But basically, what I tell the fellows, if you're dissecting right crest, you're using number 1 and number 4. So what you're seeing in this video is a cardia in my left hand, vessel sealer in my right hand, You can see caudate, cava here, right crus. So you just need to take your time. I mean, those large hernias can take up to 2 hours, 3 hours sometimes, depending on how large the hernia is. But basically, you need to have a systematic approach in dissecting right crus, left crus. You start on the right side, you get into that hernia sac. You can see the peritoneum. Peritoneum stays on the crust. You don't want to violate that plane, otherwise you get into bleeding. So you see me trying to get into this areolar tissue, avascular plane. Do that dissection, basically do that half dome from the right, and you go anteriorly, and then you turn your attention to the left side, you do the same, and then you bring that hernia sac down. So what you're doing here, step one, cardia in my left hand, vessel sealer in my right hand. I'm getting into that plane, dissecting the sac. You can see the pleura here. And then number two is pulling that down. The number two is pulling that hernia sac down. So that's the right crus. And then you turn to the left crus. And now what you do with the left crus, it's very similar to what we do with the sleeve. So number one is pulling that fundus to the side. And then number two and number four is doing that dissection. We're taking the short gastrics down, especially if we're going to do a fundoplication eventually. And then going all the way up to the left crus, try to get into that same plane. You see that plane is already developed here. So I'm going to develop that same plane from the other side, dissect the left crus, and connect the dots anteriorly, and then bring it down. So typically, I end up with a huge hernia sac in one piece. If I have a hernia sac in pieces, that means I'm struggling. I struggled up there. I'm not able to get the whole thing down in one piece. But typically, I bring the whole thing down in one piece. So right crus and then left crus. So you don't want your instruments to cross or to cause any collision. So when you go to the left crus, you're using 2 and 4, and one is retracting to the side. And by the time the fellows are actually doing the hernia, they're actually pretty good at dissecting the left crus because we've been practicing sleeve, and they know how to expose that fundus, get that fundus off the left crus, and do the left crus dissection. So that's something we practice every time we do a sleeve. And then after you do that, you do the crossover from the right side to the left side behind the esophagus to connect the dots. So again, hernia sac excision. So basically that part is done, left crus, and then like you're seeing here, we're connecting those dots to get that hernia sac down. Typically, if you get into that nice plane, you leave the peritoneum on the crus. You don't violate that. Sometimes if it's a redo, or it's maybe a large hernia after a sleeve and staple line is stuck to the crus, it's extremely difficult not to violate that peritoneum. But if it's a primary case like that, this is a large hernia, but it's a primary case. It's usually pretty straightforward. If you get into that like avascular plane, areolar tissue, it's usually pretty nice. And I enjoy those cases. Those are good cases, but you have to respect all these small vessels. Sometimes they can cause bleeding. Having 4x4 handy is a good option. I don't typically open a suction instrument. I use the 4x4. If I have to use a sucker, I'll use the laparoscopic sucker. It's cheap. And then after that, I'll close the hiatus. Some people are using V-lock. That's okay. I like to use interrupted sutures. So we practice with the fellows on doing slip knots. Slip knots are, not that easy, especially when you don't get that feedback with the XI. With the DV5 now, we can get some force feedback with some of the instruments, but not with the XI. And I use interrupted or ethibond sutures, and I do it exactly the same way I used to do it in fellowship. This is probably the only thing I continue to do exactly the same way. Slip knots using O ethibond sutures. And if I feel like there's tension on the repair, I'll do a counter incision between the right crus and the cava, and then I patch it. I patch that with the mesh. I don't do that on every single case, but if I feel like there's tension, I'll basically move that hole to the side and use a mesh. Now, there's different types of mesh. This is a Bio-A. It's a polyglycolic acid trimethyl carbonate, PGA, TMC. It's a biodegradable mesh. It goes away within a few months. And this is an old video where we're doing a C-shaped mesh. It goes around the esophagus. I've actually changed my technique a little bit. I learned that from Chris DuCoin, where you put a reverse C. I'm liking that more and more now, and because most of the recurrences I've seen, especially with sleeve patients, are kind of like to the left or anteriorly. So now I put the reverse C that looks like that C here, reverse C. And I go around the esophagus and fix that and do that. And sometimes I do basically what I call a keyhole. So I put a U shape around the esophagus, another one on top of it. So you end up with a keyhole that looks like that. Or you can take a big piece of mesh and trim it and do a keyhole that covers all layers. I've been doing this for almost like 15 years. I've never seen a recurrence on the right side. It's always on the left side or anteriorly. If you've seen anything different, let me know. But typically, it's from the left side.
Were those pledgets? We got a question in the chat about that on your repair.
Yeah, so these pledgets are the edges of the mesh. So when I trim the mesh, I use those as my pledgets. So this is also Bio-A. But you can use anything you want. Like I'm sure your attending may have his or her preference. It doesn't matter. But I don't use mesh on every case. I don't use pledgets on every case. If I feel like the crura is thin, it's not going to hold my suture, I'll use a pledget. If it's a large defect, there's tension, I'll use pledgets. And mesh. I like to use mesh. I haven't had any issue over the years in terms of erosion or so I'm a big fan of the mesh. There's some data in the we all know mesh doesn't make a huge difference in terms of short-term recurrence rate. A long-term recurrence rate, short-term recurrence rate is a little bit better. So in bariatric patients, I like to use it, especially you have a high BMI, higher intra-abdominal pressure, probably higher recurrence rate. So using a mesh, I think can help. But I know people, some people feel otherwise, and they don't like to use mesh unless they have to.
So the data, long-term data at this point in paraesophageal hernias for mesh versus no mesh shows improvements in short-term recurrence, meaning less than 3 to 6 months, but at 5 years, there's no difference in recurrence with 2 different types of absorbable mesh. So my attending does not use pledgets or mesh on primaries unless there's tension, which is me.
Yeah. You have to keep in mind, though, as bariatric surgeons, that data you mentioned, I just showed that paper from Lee Swanstrom, which, this is something that we used to basically cite as fellows, and we continue to do that. And when I talk about the 9% recurrence rate with the robotic approach, I'm comparing that to the 54% versus 59% that you just mentioned at 5 years. But you also have to keep in mind that our bariatric patients have higher BMI. So if anything, the recurrence rate is higher. So anything you can do to prevent that recurrence will help. Some videos, these are old videos. We can watch some of those videos. If you have time, please go ahead and ask questions. Shayna, you can open it to discussion, but these are, again, just basically bringing all these skills together in terms of fixing hernias, doing those cases, keep basically an eye on those different instruments that you're using for right cross, left cross, so that you don't have any issues with arm collisions or anything like that.
Liz, go ahead, ask your questions. Now it's time to harass.
Okay, thanks for this. First question, are you right-handed or left-handed, Dr. Chaar?
Right-handed.
Okay. I'm always
I always
surprised
get that question, actually, because I have 2 instruments in my left hand, and people always say, are you left-handed? I'm not left-handed. The issue has to do with those stapling procedures. If you watch people who use a right-handed approach, the minute they take the instrument out and put stapler, what you see in the video is one instrument and a stapler, which is fine, but you're basically you're limited in terms of exposure, dissection, stuff like that. If you watch my videos, I always have 2 instruments and the stapler. So I have an instrument on my left hand, instrument on my right hand, and I have that extra stapler coming from
what you're saying is that what you're saying is that you're more needy than everybody else. Is that what you're saying?
There's no question about that.
I think so.
No, to that point, I use like if I'm doing a gastric bypass or even on duodenal switch, I have one of my 2 right hands is a 12, so I can put a stapler over there and have a right and a left. I don't use an assistant port, so I find it's important if you're not going to use an assistant port that you have two right hands. So you have a left retractor, a right retractor, and you're working with your scissors or your vessel sealer. I think with your approach using an assistant over on that patient's left side, it's perfectly reasonable. But for someone who may not use an assistant, that may not make as much sense to have two left hands.
Yeah.
That's true.
Demetrius, do you want to comment? Maybe not. He uses
I'm right-handed, and I prefer having two right hands rather than two lefts. Yes, I mean, you can flip the camera. I switch the camera if I need to staple from the other side. For the switches, you don't really need to do it because I do all the stapling from the left side of the patient. For the bypass, I do switch the camera once so I can do the stapling part. I do all the stapling and then I switch back so I can do all the reconstruction with my right hand. So it's not an absolute, in other words, it's whatever works for you.
Right.
I'm left-handed and I use two right hands.
Yeah. And I think it just depends on, again, what you're most comfortable with and what technique I mean, I feel like people do things because that's how they learned it and it worked for them. And then they just continue to do it that way because it's comfortable. It's kind of like, Maher's video right now of hand sewing, that's what he's used to and that's what he's comfortable with and that's what he prefers. So I think you have to try different things and see what you like. And then once you get out of fellowship, you can either say, yeah, I'm never doing that again, or, oh, I love that, and then continue to do it. I use two right hands for everything, so.
Yeah, I agree. So it has to do with the way you do the case, obviously, and the way you line up the bowel and the way where you staple from and stuff like that. Honestly, for simple cases, it's a simple sleeve. It's not a complicated case. It doesn't truly matter how you put your ports, and it doesn't. People ask me all the time, do you truly need an assistant port? And I typically say, if it's a simple, easy case, probably not. But for complicated cases, like this case,
possibly not.
Probably yes. It will help a lot, especially if you have a fellow, they're doing part of the case and you're trying to assist and help pass sutures, stuff like that. So, when I proctor people, when I train people, I usually say, this is my approach. I recommend that you use a assistant port to start. Eventually, you may decide it's not really necessary and you can stop using it. But early on, for safety reasons, to have somebody help you pass a suture, pass a 4x4 because of bleeding,
Right.
like that, does truly help. This was a case of hernia repair, I think fistula takedown, room-wide gastric bypass. Basically, the approach is very similar to a hernia. And then what you're seeing here is an hand-sewn anastomosis in 2 layers. I'm going to skip that.
The other thing too, I would also say is that, you have to look at your resources, right? So when it comes to assistant port and all that kind of stuff, again, I'm a firm believer of one of the benefits of using the robot is autonomy. You can do everything yourself. And so if you can be 100% autonomous, then you're more likely to be able to, if you go to a new place, you're not going to be so needy and require all these things, right? So if you can just do the case you and a scrub tech and get by with that, especially when you're new and starting out, I think that's an advantage. And then I actually think that's a really great argument for hospitals to allow you to do robotics, right? Because I think that robotics has a negative connotation in some places. Not all hospital systems are really favorable for robotics. But if you're like, no, I can do this case, me and a scrub tech, I don't need a first assist, I don't need this or whatever. It just depends on the environment that you're walking into. Now, obviously, if they have that for every case, amazing, great, wonderful. But that's not I am in an academic center, but I'm not in a place where I can ask for an assistant to be at the bedside continuously to have an assist port. So you just have to see where you're at and what center you're going to be at in terms of your job or your position. So
this is another Nissan takedown hernia repair conversion to bypass. And again, it's obviously a little bit more complicated than what you saw initially, but the approach is exactly the same. It takes a little bit more time. You have to be patient, take your time. Planes may not be well developed, but you get used to it. And sometimes the fellows are kind of like lost, they're confused, like,
I think you
don't know
should
what-
save this case for our next, we're gonna have a whole seminar on
Oh, yeah?
complications.
Oh, yeah, we
and
can show that. But
difficult cases.
basically, again, it's the same approach. Right cross, you use number 1, number 4, and then left cross, you use number 2 and number 4. You take it down. You can decide if you want to keep it or excise that part of the fundus, and then you reconstruct. You fix the hernia, obviously, which is the topic of our talk, and then you convert that to a bypass. Same approach, interrupted sutures, and then you use a mesh, and then you do your hands-on anastomosis. We
Any
just talked about it.
final-
This and this.
Any final thoughts or questions
Yeah,
from?
no, I had some, if that's okay.
I'm sorry?
I had a question.
Yeah, go for it.
So a couple questions that are regarding your hiatal hernia repairs. Now, do you always go posteriorly and repair? Because I do something like a Mercedes-Benz kind of a repair where I come posteriorly and then come from all the angles. I feel like, that way you don't have to do the divide the screws to get closure. And the second thing is, actually it was to
like you close posteriorly and then you put a couple of stitches anteriorly.
No, I close posteriorly like that. So exactly what you do, then leave this and then come from right cruise and then the superiorly and then this kind of like an inverted Mercedes-Benz. Is that visible?
Not really.
Yeah, but I
Mm-mm.
don't
It's
think-
hard
I
to
don't
see.
think you know exactly what. I mean,
Well,
sometimes I put anterior sutures if it's a huge gap and if it feels like it's not going to kink the esophagus, but I don't know exactly what you mean by that inverted.
Maybe when next time I'm making a presentation, I can have a small snippet of what I do exactly for
Yeah,
that.
or bring it to the Atlanta.
Yeah, in the
I
lab
do it
session.
sometimes. What you're proposing, I do it sometimes if it looks like it will help.
It will,
not
there's
routinely.
sometimes it just feels like it's gonna come a little bit better that way. Secondly, I have never done a dissection. I never divided the diaphragm to get closure, but if you do, sometimes I feel like you might need to do that. What mesh are you using?
Permanent. I would not use what Maher uses. We have a hole in a few.
Exactly. So you use Gore-Tex then?
No, this is
No,
bio.
I use the lightweight polypropylene, and I've
Okay.
been back and it incorporates
With
really
a
nice.
coating. It's
With a
typically what I
coating,
would do.
yeah.
I do put a bio on top of it, so nothing gets stuck to it. I
I
do a
know.
mesh, a sandwich.
Yeah.
There is
The
a
board
better-
scenario, board teaching is to use a permanent mesh. If
Yeah.
you're
So you put so Dimitri, you put the permanent mesh and then you put the bio on top of it.
Correct.
actually, Gore makes a version.
Unless
of it.
unless I have a lot of fat in the air and I can put it over the mesh.
So you
Don't
don't
want it to be in touch.
you're not concerned about leaving permanent mesh next to the cable?
Well, it's not really in touch with the cave. It gets close to it, but
Yeah.
it doesn't. It's not necessarily right on it. Plus, the lightweight doesn't really do much to it. Yes, I would not use heavyweight for sure.
are you
Not even Gore-Tex. That's even worse.
Are you talking about that mesh, the Cinecore from Gore that has like
Lightweight, like
Well, he's creating
Ventralites.
something in a core, yeah.
Ventralite.
the
Is it
soft
Ventralite?
mesh. Bard calls it soft mesh.
So ventralitis,
But sorry?
ventralitis
Ventralite is
is
midweight.
lightweight polypropylene, and he's
Yeah.
putting Gore-Tex, or not Gore, sorry, Bio A over it, which is he's basically Maher. He's making his own Cinecore. Cinecore is not a poly. It's not lightweight though. Cinecore.
it's PTFE and then sandwich between
Right.
sandwich between bio A basically. But it's used for abdominal wall hernias. I don't think people are using it by the in the hiatus, but it's good to know that Dimitri is using it.
I only do it in extreme cases though, like a fourth redo or something that I don't ever want to go back. I don't do it the first time, especially if it comes easily. And if I do a relaxing incision, first of all, I don't go through and through. I try to leave the pleura. I do go through the muscle. I try to leave the pleura, but then that hole I will cover with permanent mesh.
Yeah. Now, I don't want the fellows to get the impression that I'm doing relaxing incisions for every case. No, this is like once in a blue moon. If I feel like it's not coming together, it's a lot of tension. And this is not my technique. This is what the Meester does. You know, when you're basically changing the location of that gap to the side that has a lower recurrence rate, and then you patch it.
Yeah, just one additional comment I would make, Maher. Don't go too close to your closure with the incision because you oftentimes devascularize that thing, and then I'm more concerned it's gonna fall apart.
Yeah.
Yeah,
bridge.
good point.
So I try to go farther away and try to really look if there are any vessels, so I don't take them and I don't devascularize the bridge. Because if you devascularize the bridge, then the only thing that will hold you really is whatever mesh you're using.
Yeah,
over.
good point.
The other question I had was to Dimitri, do you use a hook to make those relaxing incisions?
Scissors.
Or,
Yeah, I use scissors too, yeah,
Scissors.
which is what you saw in the video.
and
I-
anyone
the
else
way
using
Maher did.
N-form? Sorry,
Again?
anyone else using an N-form mesh?
Mm-mm.
BioA is what Gore had, but then they've come out with N-form, which is more
I
pliable.
have used
N-form is
N-form.
the same thing. It's the same thing. I'm trying to
No,
get
it's
N-form in my
actually-
house. It's
No,
just
the N-form is
but
thicker. It's
It's
much thicker and it's really
much
difficult
thicker and
to manage. Yeah. So
It's-
I've used
Yeah, more
N-form for
fun.
ventrals. And it's a little painful, honestly, but the patient did fine. And, you know, I guess hopefully I don't have to go back into her abdomen, but
Okay.
I was not impressed when I used it.
Really, I've been using it for 6 months, and I think I really like the N-form. I only use it for paraesophagals.
Are you using the pre-peritoneal or the intraperitoneal one?
In the intraperitoneal one?
Yeah.
All right, we're gonna save our mesh discussion for the next time because we're now 12 minutes over.
All right, guys,
I
thank
look
you.
forward to maybe seeing these different techniques at our in-person course. We can do it during lunch, that would be great. And during some of the during the complications. All those beeps are the faculty texting me on the back end, so I apologize. On that note, guys, thank you so much for staying with us 12 minutes late. Happy Wednesday. We'll see you in a month.